Smoking cessation is an important tool for COPD management. Do you have any other tools?
Of course. I will review management of stable COPD. Once COPD has been diagnosed, effective management should be based on an individualized assessment of current symptoms and future risks. To reduce symptoms, we will relieve the symptoms, improve exercise tolerance, and improve health status. To reduce risk, we will try to prevent disease progression, prevent and treat exacerbations, and reduce mortality. These goals should be reached with minimal side effects from treatment. A particular challenge in COPD patients because they commonly have comorbidities that also need to be carefully identified and treated. Non-pharmacologic management of COPD according to the individualized assessment of symptoms and exacerbation risks shown in Table 6. Mrs. Tubbs is in patient group B. Essential, recommended, and local guidelines for her include smoking cessation, which can include pharmacologic treatment, pulmonary rehabilitation, physical activity, the flu vaccine, and the pneumococcal vaccine. The first choice for Mrs. Tubbs includes long-acting anticholinergic or long-acting beta-2 agonists. Spiriva, or tiotropium bromide, is an example of this drug class. You usually do 2 puffs once a day of this 18 microgram strength. This medicine works by relaxing the tiny muscles in your airways, helping to get them open for a full 24 hours. The alternative choice, other than the long-acting anticholinergic, is the long-acting beta agonist. Advair, or fluticasone, is an example of this. You do 1 inhalation twice a day with the 250/50 strength. It works the same way as Spiriva. It relaxes the muscles in your airways to help prevent exacerbations. If you don't want to use either of those meds, other possible treatments are short-acting beta-2 agonists and or short-acting anticholinergics. Albuterol or Ventolin is a short-acting beta-2 agonist. For COPD, you do 2 puffs every 4 to 6 hours if you have the 200 microgram strength. It works by relaxing the muscles in your airways to increase airflow. Ipratropium, or Atrovent, is an example of a short-acting anticholinergic. If you use the 17 microgram strength, you take 2 puffs every 6 hours. This med works by blocking the muscarinic receptors in the lungs and allows the airway muscles to sleep. If you don't like any of those options, you can use Theophylline or Theo24. You take 4.8 to 7.2 milligrams per kilogram by mouth every 12 hours. It prevents wheezing, shortness of breath, and chest tightness by relaxing and opening the passages to the lungs. I think Mrs. Tubbs is available now. Do you have any other questions?
No, Emily, you did great. Thank you so much for teaching me about the RT's role in smoking cessation and COPD management. I can't wait to see what else I learned today.
No problem.
No problem.